Now it's time to know about the state of the art of the bladder cancer treatment. And to do this, I give the floor to Marco Moschini, attending urologist at San Raffaele Hospital. Marco, please, the floor is yours.
Thank you very much. Do you see my slide?
Yeah, we can.
Perfect. So thank you again. I will be, I will try. It is very difficult to condensate in 10 minutes all the new challenges and the new discoveries in the field of bladder cancer. My name is Marco Moschini. I'm a urologist, a surgeon, and I'm in charge of the bladder cancer clinical research in San Raffaele, Milano. I'm a member of the European guidelines, non-muscle invasive upper urinary tract. And I would like to present you the clinical definition and classification of non-muscle invasive bladder cancer. We are currently using the European classification, stratifying the patient in low, intermediate, high risk, and very high risk. And we have many new discoveries and many new challenges for every single group for non-muscle invasive bladder cancer, but more specifically, if we consider the intermediate risk group, in the past we knew that is a very heterogeneous group, so we need to find something more specific for this patient. On the other side, the very high risk category is validated on very old data. So for every subgroup presented by the European guidelines, we have specific challenges. As you can see here in the slide, for example, for the low risk, we need to find to avoid over-treatment, to save money and to avoid over-treatment. For the intermediate risk, to use chemotherapy or at least to substratify the patient in different subgroups on the basis of oncological outcomes. For the high risk, we have a very good drug, which is BCG, who works pretty well. And for very high risk, there is a field for and an open space for intensification of the treatment. Let's start with the low-risk group. This is a meta-analysis that we published recently in European Urology, which is the most important journal in our field, which actually say the cost for bladder cancer is increasing much and much with the time, because the cost of the drugs, the new drugs are very, very expensive. And so this is one of the most challenging situation that we are facing right now. So to reduce the cost and to being able to treat the patient in oncological safe way, but also taking care of the cost for the community. And this is the new two possibilities, clinical possibilities for the patients having a low-risk tumor, which is office fulguration and active surveillance. That means office fulguration that is not needed anymore for this type of patients to go in the OR. Is it possible to do everything in the outpatient clinic using a laser fiber and to burn the tumor? This has a very specific inclusion criteria, so all patients with no suspicion of high-grade tumor and who belong to the low-risk category. And for that, we also have data prospective trials suggesting that actually it's possible to, in some of them, to skip chemotherapy or to skip surgery. And the active surveillance, it's also a very similar concept. There are some lesions, small lesion, low grade, of course, low stage, belonging to the low risk category, which actually has no harm, no risk of progression. So it's possible just to surveil this lesion and to do repeating cystoscopy or to use biomarker to avoid treatment and also to save money. Intermediate risk group, this is also a very new challenge for the urological community. In the past, it was considered a sort of subgroup where all the patients not belonging to low risk and high risk were entering in the intermediate risk, and the urologists were not knowing what to do with these patients. Now the situation is changing. We are able to substratify also using only clinical criteria. We are, of course, still waiting validated biomarker, but in the absence of those, we can use the clinical criteria to substratify the patient and to define those who can be treated as low risk, those who can be treated with chemotherapy and those who need a more aggressive treatment with BCG. And specifically, these patients need to be treated with at least 1 year of chemotherapy in maintenance or 1 year of BCG. But let's move to the most exciting category with the most innovation for this year, which is the high-risk BCG naive. So considering the high risk, we still consider patients not treated with BCG as a whole category. And we had 3 clinical phase 3 trials who got published in the last months. So it's the Potomac, the Alban, and the CREST. I will go very fast through all of these 3. The first one is the CREST. There was the use of sazalimab, which is immunotherapy subcutaneous, and the trial was designed with 3 different arms. So all the patient included has a BCG naive high-risk tumor. The first arm, the patient received sazalimab plus BCG induction and maintenance. The last arm, the control group, were just BCG induction and maintenance as per guidelines right now. And the third arm is sazalimab plus BCG plus induction only. This is very important because one of the points of trying these new drugs was to avoid the maintenance therapy, which is 3 years of treatments that are related to several side effects and discomfort to the patients. What actually the results show that the sazalimab plus BCG induction and maintenance was superior than the control group in terms of event-free survival, with a reduction of 32% of the reduction-free survival. But unfortunately, overall survival was not significant. Very similar to the CREST, there was the Potomac trial, who analyzed a different type of drugs. So it was durvalumab instead of sazalimab, but the design was exactly the same. So induction plus maintenance, BCG alone versus induction plus maintenance plus durvalumab versus BCG induction only plus durvalumab. And also here the results were quite similar to the CREST, with an improvement in the event-free survival, which was not translated in an improvement in the overall survival. And finally, the Alban trial was the only trial who came out negative, and it was again BCG induction plus maintenance versus BCG induction plus maintenance plus atezolizumab, and this was not significant improvement in event-free survival. So this was expected to change the treatment for the BCG naive, but actually these 3 results open now to more discussion than solution. This is a meta-analysis that we published a couple of weeks ago, suggesting that actually even adding all the power of all these 3 trials to the same analysis, the results were quite similar. There is no difference in overall survival, but still event-free survival was slightly better for patients treated with this drug compared to the standard of treatment. So the points coming out from these 3 phase 3 trials, which is for the urological community, were really something astonishing, because BCG is the standard of care since the last 40 years. So this trial were very much awaited by the community, is that actually BCG is very effective. It's difficult to be stronger than BCG, also because if you do the correct scheme of BCG, it's very difficult to have then a significant difference in overall survival. So the surrogacy for the BCG naive and for the non-muscle invasive bladder cancer, when you design a trial, is fundamental, because with the correct treatment, with the correct management, we are very lucky to say the patient normally does not die from bladder cancer. Cost and side effects. These systemic treatment are related with side effects, also grade 3 side effects. It's up to us, to the urological community, to discuss how much is acceptable for this patient with non-metastatic and non-invasive disease to have side effects, and also cost. These drugs are very, very expensive. So the next step is probably to find the correct patient for the intensification, because these results show you that there is probably space to improve the BCG results, but probably it's important to find the patient who can benefit from the intensification. These are the results, the last results from the BCG treatment. And you can see here, these are all series published within the last 15, 20 years. So they are considered like the actual patient, and the progression-free rates at 5 years were around 70 to 84%, suggesting that if you treat the patient with the BCG in the correct way, with the correct schemes, actually they are doing pretty well. Last subgroup is the BCG unresponsive. As urologists, we still use this definition. So everything, the high risk is based on the response of BCG. If you have high-grade recurrence of carcinoma in situ, multiple recurrence of carcinoma in situ after an adequate treatment of BCG, patient enter in this subgroup, which is the BCG unresponsive group. The guidelines still suggest radical cystectomy, so to remove the bladder in this patient, because it's as well known that the patient who has high-grade recurrence after the BCG treatment at a major risk of progression, and not only progression, but also developing metastasis from the disease. But right now, it's also an exciting time, also in this setting for urologists. There are plenty new drugs who are tested, and several of these are already FDA approved in the treatment of BCG unresponsive as alternative to radical cystectomy. We have here gemcitabine docetaxel on the European side. It's very important because these drugs are very expensive. They are not EMA approved, so we are in a sort of situation when there is a gap right now. We can include patients in the trial, but still we have only this drug, gemcitabine docetaxel, at our disposition. We have approved it off-label, so there is not an actual approval, but it's still the only solution for something which is already FDA approved to use here in Europe. And does it work with two different drugs, gemcitabine and docetaxel, subministrated intravesically? So first gemcitabine, then after 1.5 hours you instill the second drug, and the results are quite good. You have to consider that this patient has a high risk of dying from the disease, and these are the results for our series published with 68 patients, event-free survival at 12 months was 80%, and also from these we published the first European collaboration, first results coming from Europe regarding this very important group of patients, suggesting that it's possible to save the bladder in this patient, but it's also possible to avoid progression. I will go very fast, just to say so that here this is one of the open challenges, at least for Europe, to have new drugs also in this setting to avoid radical cystectomy. So thank you very much for the attention. These were all the ongoing trials, also recruiting in Europe, but I think I'm short of time, so I thank you again for the attention in the space.